Working. Welcome to Grand Rounds. You all have found a seat all right? To those on distance, welcome to Grand Rounds. To those in the audience, today's Grand Rounds, as you can see, is about stroke care regionalization. Dr. Charles Tighe from the Division of Neurology will be presenting. I wanted to acknowledge that we're on the unceded lands of the Coast Salish people where we live and work. Charles.
Thank you, Barry. The Grand Rounds is very timely because we've been discussing a lot about a stroke prevention clinic at St. Paul's Hospital and Province Healthcare. And of course, with the new St. Paul's Hospital materializing, we're excited and there's a lot of energy. Dr. Valerio, who's now the stroke lead for our division, has done a lot of work in terms of establishing a stroke prevention clinic or stroke clinic at Province Healthcare. The clinic runs once a week, and we're looking at ways of improving it. And I say it's timely to present it in medicine rounds because I think it's very important to involve you guys. And I hope when you hear the proposal or what I envision, it would generate a little bit of excitement or some interest in the internal medicine group. I have no financial disclosures or disclosure of concern, but I say that sort of the proposal, thinking about running a stroke clinic, is not well worked through. There are many details that will require work, and my vision of a stroke clinic is not really a consensus in a division. So this is still going to be work in progress. So I just want to make that clear. The outline I want to, for hopefully maybe some house staff is online. I think in the last 20 years has been very exciting in stroke care. The data has been amazing, and like many parts of medicine, is developing and evolving very quickly. Very briefly share some of our regionalization efforts and explain that. I think we are so busy doing our work. Everyone is busy in their little niches that I think it's important to remind everyone what is happening in terms of stroke care and how we are sort of dividing up the work in our community and why we're doing that. So first, I'll just maybe the first 10, 15 minutes for some of our house staff review the important papers that have come out. The first one, of course, is the NINS trial in 95. the first trial demonstrating that thrombolytics can be effective in treating acute stroke. And I want to sort of emphasize here the time window being 3 hours, because prior to this, we're treating patients that come in and we don't know what the time of onset, patients that have devastating or significant deficits and abnormal CT scan, and we're thrombolysing them and we're getting bad outcomes. So what's different in this NINS trial is that we're catching them early, treating them within 3 hours. And in fact, about 40% of those patients treated were treated within 90 minutes. And what we'll see as we move forward to where we are today with endovascular therapy, we're getting a bit more sophisticated understanding how the physiology works and being able to move away from time and looking at CT imaging to guide us to find the patients that are appropriate for therapy, right? So nonetheless, the NINS trial was very effective. The number needed to treat to prevent one patient that has significant disability, the number needed to treat is 10. And although there were hemorrhagic transformations, symptomatic hemorrhagic transformation, the numbers were acceptable. The treatment was effective. We'll talk a little bit about the modified Rankin scale a little bit because we use it a lot in stroke trials. The key here is sort of the 0, 1, and 2. These are the people that can function still independently in the community, whereas 3 or more, these patients are going to require some degree of support, where you don't want to be in 4 and 5 because those are the people with severe disabilities. This is a very easy to use scale, and I think we're going to come back to it over and over again. Although the NINS trial was very effective, there was a big issue. Now, there are probably multiple issues, but the biggest one is logistics. Patients typically present much later, right? I mean, that 3-hour window at the beginning was almost impossible. And although we had a very effective treatment, patients would not come to the hospital in time. And when they come, they'll sit in triage, and by the time the doctors see them, it would be too late. They're outside that window. We had to grease the system to be effective to be able to deliver a treatment. And there was, and probably still some degree of anxiety about treating acute stroke with thrombolytics, the risk of hemorrhagic transformation, and making our patient not better, but worse, right? But really that hemorrhagic concern, if we follow the protocol, is not an issue. Patients will do well, and we will thrombolyze mimics. We'll thrombolyze people that do not have acute stroke when we're aggressive, but most of the patients do not have bad complications. We can come back to that in discussions later. But in terms of the logistics, we were recognized 3 years after the NINS trial came out. We weren't using TPA, even in the big American centers in Europe. TPA rates are only 3 to 5%. So we have a good treatment, but it was not being used. We need logistic tools that can identify the patients early. We need patient education, and we need to improve our infrastructure in the hospital to deliver it. So the pre-screening or pre-hospital identification tool, the first one came out a couple of years after the NINS trial, was the Cincinnati pre-stroke scale. And that has been modified, adopted as the fast mnemonic, which we're using now in many places. So the facial paralysis, weakness in one arm, or lost ability of speech, T's for time. We got to get those patients to the hospital quickly. Yes, the fast mnemonic will not capture all strokes, but it is quite sensitive, quite specific, and very easy to use. So in terms of balancing sort of the pros and cons, it's sort of the mnemonic that we embrace. And with that, we can do patient education a little better. I'm sure that everyone's seen the commercials on TV. So this is helping, and I'll show you some of our data a little bit later. 13 years after NINS, we're able to extend that time window. 3 hours, we're able to get to 4.5. And the main reason now, as I'm going to talk a little bit more about later, is the improvement in technology. We're able to utilize the CT scan findings. And in this trial, extending it 4.5 hours is really looking at including the patients that have near normal CT scan. We don't want to be thrombolizing people with strokes that have been completed, but if the CT scans are looking relatively normal, those are the ones that are potentially suitable for treatment. And even though in this study, they're extending that time window out to 4.5 hours, the hemorrhagic rate was actually lower than in the NINS trial. And here again, the Rankin scale, modified Rankin scale is demonstrating that we can increase the number of patients in the 0, 1, and 2s from the placebo to the TPIP thrombolytic group, right? So after the NINS trial came out in the UK, they were recognizing that it's not being utilized because the logistic was a problem. So when they did the stroke audit prior to 2010, many centers were treating only 3 to 4% of stroke patients. Some of the stroke centers were treating relatively small volume. So the UK stroke strategy developed this spoke and hub stroke management. And what they did for the city of London, they designated 8 hyperacute stroke centers. The idea is that these stroke centers are going to get greater volume. They're distributed in a way that everyone in London can get to one of these centers in 30 minutes. And then all the other centers would be bypassed, right? So by doing this, those centers can be very, or have better resources and just geared towards treating TPA patients. All acute stroke patients would go to these hyperacute stroke centers. So this is sort of the geographic localization of those centers. And this is important because we kind of adopt this strategy for Vancouver Coastal. And they were very effective because within 3 years, the TPA rate went from 3.5% to 11%. Stroke mortality reduced in 3 months by 25%. The length of stay was reduced. Cost of providing care was better. And their idea of using that geographic distribution of the hyperacute stroke units was effective because 98% of stroke patients were able to get to the stroke center within 30 minutes. So in Canada, and we have the Canadian best practice recommendations for stroke care. We are adopting those here in Vancouver Coastal, first released in 2006. And the updates are released every 2 years or as needed, just to disseminate the stroke-based evidence, the evidence that are proven to improve the outcome. The most recent being in 22, and I'm going to refer to that a little bit later. So around 2013 or so, when we were starting to implement the spoke and hub pathway, Vancouver Hospital was sort of the natural site for it to be the hyperacute center. They had the neurosurgery services to deal with some of the complications that may occur. They have the neuro ICU. Lionsgate Hospital, because Vancouver Coastal captures also the Seychelles and the coastal region, was also sort of a geographically preferred site to capture those patients on the coast. They also have neurosurgery, although they were a little lacking in sort of the neurology support. Geographically, they were a better location. Whereas at St. Paul's, although we have very strong and large numbers of neurologists here, very good radiology, we didn't have neurosurgery service in-house. And our proximity to Vancouver Hospital just didn't make sense to dilute the stroke volume for one center to be going into 2 places. There was some concern about sort of losing sort of the stroke care, acute stroke care at St. Paul's Hospital, but still with our downtown east side population, with the cardiology services at St. Paul's, we maintain a fairly large number of stroke patients in our facility as well. Before we talk about the regional results, I'll just very quickly talk about the endovascular trials. Because like the NINS, I mean, so much effort has gone into it, but all the trials have been unsuccessful until 2015. And then one after another, a whole bunch of trials were published in 2015 demonstrating tremendous results. And I think the improvement is really in the technology and the CT perfusion studies, being able to identify patients that have salvageable brain tissue and treating those patients rather than all comers. And if we're able to select patients, we can extend that window out to 6 hours. And even when we're treating, 260 patients in this study, significant strokes, NIH stroke scales in the high teens, the number needed to treat was only 7 to improve 1 from disability at 30 days. One thing that this is just a one-liner here is that aspect scale of 9. This is really a measurement of the emitting triage CT scan. Because although these patients have significant deficit
show on the screen
with an NIH, sorry? Yes, please, sorry, the audience on Zoom, if you can just mute yourself, that will help me. Thank you very much. But that NIH stroke scale of 17, they have significant deficit, but their CT is near normal. And the rationale is that the brain has not yet infarcted. They have dysfunction, and dysfunction is coming from stun or brain that is hyperperfused, and these patients will get better. The challenge is really finding these patients, right? Having these patients come in. But the CT imaging is getting better and better. Now, without going through all of them, because they're really all very similar. In 2015, a bunch of studies that published, each one getting better in the number needed to treat. We know with large vessel occlusion, endovascular therapy is the way to go. And again, because of limited resources, it's a very expensive treatment, right? And you need a lot of personnel involved to provide it. It's very challenging to have multiple sites providing it if they don't have the volume. The last 2 trials published in 2018, the DAWN and Diffuse 3, were even more impressive because now the CT technology is getting even better. They use the software that they're using now at Vancouver Hospital, the Rapid software, to identify patient really automatically, making the process automated. And the number needing to treat is down to about 3. Yet we can treat patients up to 24 hours. Now there's discussion where is time really an issue now for managing these patients, and maybe the technology can help us select the patient understanding of physiology better. I mean, that's very exciting. It's great. And we see phenomenal results for some of our patients. But what are the numbers, right? So these are the data from the Regional Steering Committee for Stroke Management in Vancouver Coastal. So in 22-23, we're seeing over 1,000 stroke patients in Vancouver Coastal, most of them in Vancouver. And the TPA rate is excellent, it's 15%. So that's good. That's sort of what we expect for a urban center with a good stroke program. But not only that, if we look at the patients that were triaged, that actually come to the hospital in a timely fashion within that 4.5-hour window, we can actually deliver TPA to 25% of those patients. So, I mean, that's awesome. And if you look at it, the number of TPA patients in that year, about 150, and then majority of those are presenting within 4.5 hours. That's what the expectation would be, right? But we can treat some with unknown time of onset because of our improvement in CT technology. But a couple of hundred patients, some of them are getting endovascular therapy. A study, an estimation this year, suggests there's 100,000 stroke patients a year in Canada. And if we look at Vancouver Coastal having a population of 1.25 million, 3,000 strokes in our region, but we're only with our acute treatment, reaching a small percentage. And that's why the stroke prevention clinic is so important. We do have a stroke prevention clinic, but these are really triage systems trying to identify patients that have symptoms, who is at high risk, and how to best manage them. But I'm going to sort of emphasize that a stroke prevention clinic really require your support, our internal medicine colleagues, and we need to develop a much better program. And maybe moving, with the energy that we're going to have with the new St. Paul's Hospital, is whether or not we can develop a program that can provide the evidence care, the evidence-based medicine in stroke care to more of our patients, to not just the 300 or a couple of hundred patients, but all 3,000 stroke patients and beyond. So we're going to leverage some of the resources in the community. And although we can prescribe, ACE inhibitors and statins and make recommendations, but the follow-up is not ideal. Patients are not always doing that. And although we know physical activity is important, we have the Healthy Heart program that demonstrate physical activity is very important to vascular endpoints. We don't have anything for our stroke patients, right? And even cardiology rehab is somewhat limited. Physical activity will improve health. It improves all the vascular endpoints, and studies will show that people who are more fit have lower mortality rates. And we look at stroke patients, comparing stroke patients to normal or controls, we know that the stroke patients are less active, right? Not only that, there are studies that demonstrate we can modify cardiac rehab and apply that to post-stroke patients. And in 6 months, relatively short period of time, all their vascular parameters improve. And the current or the most updated best practices guideline for stroke recommends at least 4 to 7 days of physical activity for patients and accumulating to 150 minutes per week. So this is a recent report from Participation that I can find. Unfortunately, most of us remain sedentary. A good 40% plus do not do 3 hours of sort of low intensity exercises a day. This is walking, standing, right? I mean, I think we are probably all at risk because we are, unless you're doing ward service and you're walking from point A to point B all the time. But in the office, we're very sedentary. So we need to do more. And I reached out to Park Sport, partly because some of my Parkinson's patients have programs already in the community. And I think the Park Sport had developed this all bodies community recreation and fitness group. And when they say all bodies, you're going to include patients with disabilities, patients with chronic disease, and elderlies to get involved. But this is only, the activities are only distributed to 3 community centers at this time. I think there is resources, spaces available in a community that if we develop a stroke program, a stroke prevention program, that we can liaise and leverage some of the services that are out there. Obviously, rehabilitation can't occur in the expensive facilities of acute care medicine, but there are options out there. We recognize that people generally are inactive, but we look at stroke patients, they are even at more disadvantage because of disability after a stroke, the fatigue, the loss of confidence, the fear. So there's good literature demonstrating after a stroke, patients do not stay active. And although we can tell them in one consultation or one assessment to be active, they may have the motivation, but there's really not the means for them to do it, right? Yet this is probably the biggest, how we can make the biggest impact to their overall well-being and outcome. Very briefly, I'm just going to talk about the lipid management and diabetes. And, for our stroke consults, I think it becomes almost repetitive. And that we talk about this targets that we want to achieve with the statins. And we don't talk about triglycerides so much, but they are there in the best practice recommendations. And although, we see most patients after a stroke will have be on statin, but I can count in one hand the number of people I see that are on additional medications beyond a statin, yet they do not achieve the LDL targets, right? So I think we need to do better as consultants, but also we need to involve primary care physician to look after these risk factors more aggressively. And then the diabetes, I think we know where they should be, but as a neurologist, and I think I do general neurology, but I can't keep up with the diabetic medications. I mean, diabetes has evolved so much in the last 10, 15 years. All my training is really Stone Age, caveman age. All these new drugs, I just don't know how to use them. And we really have to lean on our medicine colleagues and endocrinologists to help us using some of these newer medicines and treatments to get patients into their target range. Now, hypertension is very important because, all the vascular risk factors are significant, but hypertension is probably one of the more well-documented, well-studied risk factors. And the targets are pretty aggressive, 130 to 140 systolic. Most patients don't get there. They may be on 1, 2, or even 3 antihypertensive, but they do not achieve the goals that we want to get. And I'll come back to the PROGRESS trial in 2001. And I think this kind of illustrates how important hypertension is for stroke prevention. And we need to do a better job. Here, we have about 3,000 patients in treatment and 3,000 in placebo. And the treatment group is a combination of diuretic and ACE inhibitor. So it's important because this is a very low risk population. These patients are pretty healthy. I mean, look at their mean blood pressure, 147. I think most doctors would just leave them where they are because they're not going to do anything different. And look at the prevalence of diabetes in this group, only 13% and 16% with coronary arterial disease. They're a healthy group. The important thing I want to emphasize too, the qualifying event, these are all post-stroke patients, but the qualifying event was 8 months ago on average. And that really puts them at low risk because we know after a stroke, you're going to have another one. You're going to have another one early. We need to catch them early. But still, the study is able to demonstrate a significant reduction in the stroke events. 420 in the placebo group and then 307 in the treatment group. Just to sort of illustrate a more recent study in 2019 is a German population, but I think it's going to be generalizable. That after a stroke, majority of the recurrent strokes happen in the first year. In fact, the first 90 days. So we want to capture them early in the progress trial when the average time frame to their admission or the qualifying event was 8 months. We're seeing a population that's relatively safe, relatively low risk. So here's just a summary of the progress trial, again, demonstrating the last one is all strokes are improving. Those are the numbers that I'm giving you. But all strokes will improve with blood pressure control. But I don't think we're doing a good enough job. So here, I'm just going to talk about sort of what we need to do, because I think it's important to continue with our acute stroke care efforts, and that's very expensive, but it's exciting, and we're learning a lot. But to provide good medicine to our general population here in Vancouver Coastal, what we need is a stroke prevention clinic that we can include thousands of patients, not hundreds, right? And we need not just neurologists, but also general practitioners, maybe even nurse practitioners that can help us. And we need to leverage the community centers to provide the facilities, the spaces that we need to do stroke rehab, right? We provide them the opportunity. So we need, a core team. We need the neurologists. We need internists to do their assessment and nursing support. We have already in our program now a very good connection with vascular surgery, doing the carotid endarterectomy in patients who are identified. And we need subspecialty services because there are some complex stroke patients that may need hematology and cardiology support as well. But in addition, we need dietitian and social worker. The social work is extremely important because although we can make recommendations to take medications A, B, and C, and to exercise, many of the patients in our community do not have the means. There are other impediments that prevent them from taking our advice. So we need the social workers' involvement to make sure that barriers are removed as much as we can. And maybe the most important thing is that physical exercise component. We need kinesiologists, physiotherapists to liaise with the community so that the facilities there. I mean, it's not going to happen in acute care. Even at the new St. Paul's Hospital, we're not going to have space for that. But there are many community centers, public ones, private ones. We need to use all of them. And we need to make sure that this is a recurring event. We can't provide one consultation and say, all right, you go and do that. Because family doctors in their setting, they just don't have time to deal with it. I think a family doctor can participate in a stroke prevention program, but they need to be in a setting where they can address all those issues. And even though right now Vancouver Hospital runs a stroke prevention clinic, the clinic doesn't have this opportunity to provide all these care that is needed. And this needs to be recurring. It can't just happen once. We need to have a infrastructure that can provide this in a recurring, to capture these patients and hold them there. Now, Healthy Heart Program, geriatrics, fall prevention, and other programs can also feed patient into there. I think there's a lot of synergy that's involved. And with our rapid access clinic in the hospital, I think there's got to be some sort of coordination so that we can provide better care. And the intake for these patients, I kind of alluded to the different locations, but I think the emergency room, the inpatient services are very important. The metrics, right now with Cerner system, we are able to identify the patients, but not only that, the Cerner system can really help us track the outcome, the stroke and other vascular endpoints. But I think in addition to preventing strokes and vascular endpoints for these patients, quality of life assessment is very important, and also their modified Rankin scale. Because I think with a clinic like this, we can improve health, we can improve patients' sort of lifestyle, and their feeling of well-being. This sort of improvement will also go hand in hand with the reduction in stroke that we're going to see. And I think in terms of increasing the numbers, so sort of the numbers that we want to see, we estimate maybe 3,000 stroke in Vancouver Coastal in a year. I think we need to capture all of them and more, right? And not just stroke patients, but other vascular diseases. And it's a busy clinic. I mean, we, as a neurologist, we can't do all of them. We can assess the patient, but a lot of the follow-up is going to be done with primary care physicians. We already involve family physicians, and probably a nurse practitioner would be a great sort of asset for us. And I think, even at 3,000 patients per year, we're going to be working 50 days a week, 12 patients a day, right? It's a lot of volume. And although that's going to take a lot of resource, a lot of money, it's only going to be a fraction of the cost of acute stroke care. Yet I think we can provide better outcome. So I think the internal medicine buy-in, I don't know how the group feels, whether there's internists in the audience that are maybe slightly interested. I think internal neurology will certainly be willing to take the lead, but I don't think we can run a clinic in a silo, just with neurology. And there are other centers, as I'm kind of doing this, preparing for these rounds, there are many centers that provide a multidisciplinary clinic like this. And in talking in my sort of preliminary discussion at the Parks Board, there is interest to coordinate with acute care hospital to provide these sort of services. So I think I'm just gonna stop there, and hopefully there will be some discussion, some interest from my internal medicine colleagues. And I'm happy to also talk about some of the acute stroke care management, because I feel there still may be some hesitancy in primary care, in emergency medicine about treating acute stroke. I'm happy to talk about thrombolysing mimics, because I have done it, and I know I'll do it again, and I'm not shy about that. We need to do it. We need to treat stroke more aggressively. So anyway, I'm going to open it up. I hope there's some discussion from the group. Thank you.
Maybe we'll just ask if anybody online.
Anyone online that may have a comment or suggestion? I'm not sure if there's anyone there.
Anybody in the audience have a comment or question for Dr. Tide? If not, I'm going to take the chair's prerogative. Since physical activity seems to be the most translatable, without intervention by sophistication or professionals, is there any idea of having these clinics in community centers that have gyms or pools, and people go to their community center as part of it, and as part of their overall participation, have their blood pressure checked and have their vital signs checked, rather than having a clinic of stroke prevention in a hospital or in another setting where people. So I just wondered if you'd said stroke centers, that's for in case of acute strokes in London. I was just going the opposite direction, seeing if there would be a difference in outcome if we use community centers.
I think that's a great idea. And I think that's where maybe even nurse practitioners can help us. And I think, trained physiotherapists and occupational therapists can help us. I think we need the social worker in a community center, because there's impediment. Patients may be motivated, but they cannot get there.
Why don't they walk there?
Well, the issue is some of them are not close to the community center. And the other one is sort of that loss of confidence in after a stroke.
Sorry, but I'm talking about pre-stroke.
Well, for sure. I mean, and look at the data from participation.
Yeah.
These are not stroke patients, but they're not doing it.
Yeah.
So I think we've done a great job in public education in saying, like, these are fast symptoms. You got to come to the hospital. It's working because we see more of them come, right? We need to do more in terms of public education about exercise. And just to go back to that point, you know, with the data, when I'm doing preparing for this rounds, if the physicians emphasize it, the patients would do it much more likely. If we are not emphasizing and not reiterating it, you know, other people will tell them, but you know, we're very fortunate because the patients put a lot of trust in us. When we tell them to do it, they're much more likely to do it. So it's very important that we enforce it. But not only that, then we got to give them the opportunity. But right now, there are very few opportunities.
So I would suggest, though, that we need to model it, not just suggest it.
Yeah. And we need, I agree with you, Barry, that we need primary prevention.
Right.
As much as secondary.
So we as physicians have the responsibility of doing what we're suggesting other people
would
like them to do.
Yeah, that's right. We need to be active as well. Yes, yeah, hi.
Charles, thank you. Sorry I came late, but I think that emphasis on prevention is so critical. And I think what people now, one of the things they're worried about is brain dementia and brain health. And I don't think the public knows that, like, one of the few things you can do to actually reduce your risk of dementia is vascular health. And I think if we link those things, people are more interested.
I think it is getting to the lay press, right? It is not just the vascular health, but the neurotransmitter milieu in the brain improves with exercise, the endorphin release that we get. You know, we recognize it in Parkinson's disease in particular. I think the difficulty is that, you know, we promote drugs more because, I mean, there's maybe a bit more push and more attention, always focusing on the medication. Yet we all know that the exercise component is there and it works, but somehow it doesn't translate. And I think we really need to really liaise with the Parks Board. So, you know, it's never going to happen within our walls. It's just we don't have the space to have exercise program. And I'm going to follow this up because actually I get the feedback from my Parkinson's patient that have programs in the Parks Board. And the Parks Board is doing this, but they're not connecting with us. I tell them we're interested, we want to, because there's no way we're going to have the facility do that. So I hope that maybe when we move forward and expand our stroke prevention program, we liaise with the Parks Board and get our ally health involved, because I think we can't do it alone. I mean, we may be able to make some impact, but we're going to make the greatest impact by incorporating or involving everyone. And I think the first step is getting internal medicine to buy in and getting family practice. You know, I think we need more primary care physician in a stroke clinic setting, because family doctors in the community have far too many distractions, right? And then, so we're not doing a good job. That's sort of my point of this. Acute stroke care is very exciting and everyone's got everyone's attention, but we are starting to forget how we can actually reach out and capture more of a patient and actually have greater impact at a lower cost.
Well, you know, I'm just going to take the opportunity to say I'm the public. So I see that I should do this from the lens of neurology/stroke.
Mm-hmm.
But now I'm a cardiac patient, and I see I should do this from the lens of cardiac. And now I have hypertension, but I see a different lens. So in part, we're responsible for a lot of different lenses. Not you, but, and I think so participation is one thing, but that was a different end game at the time. Maybe we should actually be more sophisticated in what we're trying to achieve and show these pieces of information back to the community center where people are to start in that area, so that we at least achieve one of the things that was going to be helpful, and that's some physical activity.
Yes.
So in any case, I'm beating the wrong drum, and I represent Specialized Bikes. So for those of you, that's a financial interest that I am disclosing.
Yes.
Any other comments or questions? Yes.
Hey, Charles. So even though St. Paul's Hospital is not a stroke hub, you still have stroke and you still manage it. So is there any data or any latest outcomes, and what are the areas?
Looking at the report cards, Alex, they're actually starting to lump. Initially, they divided up VGH, St. Paul's, and even Richmond. But now Vancouver is all kind of grouped together because the diversion protocol is working very well. And so with the only division, the only separation that I see in the report cards now is for Vancouver coastal. So the coastal, urban, and rural region, and then Vancouver as a whole. So the data is not being separated that way. But with Cerner, it's a fantastic system that we're moving towards an electronic digital. We can find out information, Alex, but I would say that the outcome is going to be the same because we have such a good working relationship with our colleagues at Vancouver Hospital. Patients that have large vessel occlusion, that are candidates for endovascular therapy, they move over there very effectively. I don't have any concerns that patients presenting here that are appropriate for treatment will get delayed.
But maybe because another place is a stroke center, then they have more physiotherapy, care, and all the other folks. So it's not. So the outcome may not necessarily be in the management, but in the chronic stroke afterwards because of that.
I'm actually glad you brought it up, Alex. When I was doing the stroke lead, when that data was being separated, St. Paul's Hospital always did better. We always came up sort of our Ally Health, 7CD. They're excellent. I mean, in terms of the swallowing assessment and all the best recommendations from the stroke care, we always score higher than other. Well, I wouldn't say always, but fairly consistently. But now that data is not. I didn't see that in the report card. I have not been as involved, but I don't see that separation. So I think our Ally Health at St. Paul's Hospital do very well. In fact, I think if we had the bed capacity, we can take stroke patients from Vancouver Hospital and provide the convalescent care. And patients can move from our facility to Holy Family and get excellent care. And I think that's the way it should go. But, it's not going to happen because we're always in overflow situations, right? I mean, there's more demand than there are beds, right? But thank you.
Charles, can you describe the flow, the process? I have a stroke, or I think I'm having a stroke, and I come to an emergency at any place.
Yeah. Well, if a patient, Barry, you're not going to have a stroke, but if a patient is having a stroke, they should call 911 instead of going to the emergency.
Right. Okay.
And 911 will triage them with the fast protocol within the 4.5 hours. They wouldn't go anywhere except Vancouver Hospital.
I know, but I don't have a telephone.
Okay. So if you walk in, Barry, we're not going to send you away. We'll treat you.
I don't mean that.
Yeah.
But I mean, I'm talking about the 3 hours. First of all, it was 3 hours.
Yes, now it's
Then
4.5.
4.5 hours. And the 3 hours were decided on what you said, what I said.
Yeah.
It could have been 20 hours. But I just said that because I know 3 hours. So if I hit the emergency room, I walked in.
Yeah.
However, if I'm driving.
Yeah.
How quickly will I go through that? Is there some sort of algorithm that gets me through there quickly?
Yeah, there is. And if you are a walk-in here, you're gonna get screened here. And now the timing, like I say, we're moving away from timing. We're looking more and more at the CT scan. So even if you're outside the window, you have a very good CT and you have a significant deficit, we're going to treat you like you're someone that may be potentially be able to improve. But if there's a hard beyond the 4.5 hour window, you're a little bit hard pressed. You're going against the protocol, and the complication rate is going to be a lot higher. But to answer your question about the time, we are putting less and less emphasis on time and more attention to the CT scan findings. I can't speak for other hospital, but I can tell you at St. Paul's, you'll be treated here, you'll be triaged here. You have a large vessel occlusion, you may get started with IVTPA and move over to Vancouver Hospital. According to the protocol, if you go to Mount St. Joseph, they will move you by ambulance to Vancouver Hospital, not here. Now, the other hospital, I can't speak for them, but I know the triage protocol for province healthcare very well. Yeah.
But you're talking about, is there, like when you hit the door, it starts.
Yeah.
And you are in the scan fast. We're called at the same time they call residents. We're in a car
Right.
coming in as the residents are coming in. We're not waiting to say like, oh.
Yeah.
So it's a full court press to
Okay.
get the scan, the blood. It's that we have a certain protocol and they get triaged as a hot stroke, which means we see lots of not so hot strokes as hot strokes.
Yeah.
Which is fine. We don't mind.
Right, that was the question. I mean, is there a way of
20 minutes to get your CT is our sort of target, right? So when we and
But
we
all of us have been, sorry to interrupt, all of us have been in our waiting room,
yeah.
where chaos isn't even organized.
Yes.
Yeah.
It's just chaos.
Yeah, we have done simulations, Barry, and maybe we should do more, but we have done multiple simulations in the emergency room. So to help the triage desk recognize these fast stroke symptoms. So it's not perfect, but we try. I mean, and the simulation is sort of the best effort that we can do.
It was interesting, the worst stroke times were people who had their strokes when they're
In the
already here,
Yeah.
in hospital. And so when you hit the door, we're pretty good, it's like all happens, and if you have it up on, and so we have a new protocol for that, they come down, and they go into the trauma bay, they go straight down, because trying to bounce around.
Yeah.
That, we had terrible outcomes if you actually are.
That's
An inpatient, right?
That's a St. Paul's Province Healthcare Initiative, and being our stroke nurse at that time, did a tremendous amount of work. And actually, Vancouver Hospital have used a lot of our learning from that. But yes, still it remains. If you're going to have have a stroke, inpatient is probably the worst place to have it. Yeah. But thanks for everyone's attention. I appreciate it. Okay.
Thank you.
Oh, thank you, Barry. I'm glad that I hope there was some medicine interest to share that stroke clinic.
Well, I'm so interested in everything. I'm not discriminating. Are you going?
So you're kind of talking a little bit about the code stroke protocol, right? Like
Yeah, but that's for the inpatient.
if someone's on the ward, you don't have to be sure that they've had a stroke before you call neurology. You should be calling the code stroke based on the symptoms.
The protocol is that you talk to the neurologist.
Yeah.
Because we're going to get so many mimics.
Yes.
So I understand you're saying, I mean, it's more effective, just call the cold stroke.
Yeah.
You're sure. But, the issue is that we don't know calling the cold stroke is an internist or a nurse practitioner in ENT.
Right.
And they're, every dizzy patient, they're going to call cold stroke.
Right.
Then it becomes, the sort of, it dilutes the volume or dilutes the sensitivity.
Right.
Then no one's going to be paying attention.
Right.
But I agreed. I mean, if you call me, I trust your assessment.
Right.
So the way the protocol is that you have to discuss with the on-call staff so that we get fewer mimics. Still, mimics exceed 50%.
Sure.
Right? So it's a mimics that kind of just, if we get 80% mimics, then no one's very excited.
Yeah.
Right. So that's sort of the concern. And that's the protocol. We got to talk to the stroke on call first.
Right.
But anyway, I think we really need medicine participation in stroke clinic. But anyway, I hope these guys have some interest. Yeah.
Well, in what context do you want medicine to be involved?
Manage the diabetes and hypertension. Because, we can make recommendations because internists don't do. I mean, the neurologists do not do that. I mean, I've never seen a colleague prescribe, say, Ezetrol because they cannot achieve the LDL target, or they complain of myalgia, right? So, we need you guys, and I think we need nurse practitioners because the volume is too high. Yeah. So I'm going to follow up with. Sorry, I forgot your name. Charles. Yeah. Nice to meet you. I mean, I saw your name many times and we share patients. Yeah.
Back in Ontario, where they have stroke prevention, full stroke clinics, and it's all brand new.
Yeah.
The government actually pays for their clinics to run it. If you do that, they pay for it.
Yeah.
Group of people that go out.
So a lot of GIM actually does it there. But I think here it's not a thing. I haven't seen it. But what I've seen, like here, we have something called vascular health.
Yeah.
Basically looking for one-stop shop that can address all those problems.
Yeah.
We have it here in St. Paul's vascular health clinic. Do it. Hypertension, cholesterol problems, basically.
But at the same time, it's kind of hard because we don't have any of the resources that endocrine has for managing diabetes. We don't have pharmacists, we don't have a nurse educator, we got nothing.
But you know, I think that's what we need
We
to
don't
do.
even have a pharmacist on our general medicine.
So yet, you know, we divert. We only need 10% of the funding that acute stroke care needs, and we've run a very good stroke prevention clinic. But you know, that's sort of the myopic view of the government. They fund things that are
So that's why
in
general
vogue.
medicine doesn't do long-term outpatient management of diabetes, because we don't have the resources to
So
do it the way endocrine does.
So that's
We
why
don't
I'm
have
hoping
any
that
of
maybe with the new St. Paul's Hospital, I mean, this may be an opportunity to somehow ask for that funding if we can demonstrate that we can make it effective, right? You know, if we can show some data. And I think Cerner, you know, there are some shortcomings in Cerner, but I think it's really good for tracking these results. But unfortunately, I think it's a difficult barrier to overcome. You know, it's hard to convince administration that a little bit of funding into this would generate much better outcome, right? And you know, but if we can do it, I think it will be phenomenal. I think for St. Paul's Hospital. So Bear, are you running the outpatient program or not? No, Tony. Yes.
There is that particular kind of vascular health clinic. So I mean, it's like for these patients, like you're disabled. The last thing you want to do is go to 3 separate hypertension clinic, a diabetes, and a cholesterol clinic.
And then you have to not only go to that for the rehab part and the other part, you have to go for, so you go to the lipid clinic.
Yeah.
Which could be in endocrinology,
Yeah.
because they have a lipid clinic, or could be in cardiology, because they have a lipid clinic.
But that's why you know, as a general internist, I think they're so relevant now with the way healthcare. I think we have gone very subspecialized, but we need to pull it back together.
Well, I don't disagree, but if we're talking about reorganizing healthcare, give me a call.
Hey, Barry, thank you.
All right.
Yeah. So I'm happy to talk to Tony as well. I mean, I think it's the new St. Paul's Hospital is kind of an opportunity to make that change. And I hope that's why I thought this was kind of timely. And if we can get that in there and get some funding, you know, I mean, we are happy to participate as neurology, but we can't do that.
I totally get it, because I remember seeing that back in Ontario. That's the way it is.
There are a few parts of the world that have these multidisciplinary clinics. But I think the other part, I'm going to follow up with a community center. So that ABC program that they have, because can you imagine if we say, okay, well, you're going to go to your local community center, and then this is where you're going to do your exercises, right? And I think some of us, we may have to just, you know, have a nurse practitioner to liaise. Yeah.
I mean, the vascular health clinic is actually run by GIM here.
Yeah.
So they take care of all those things. And then I've seen that if the diabetes become too resource intense,
then they'll refer them to
but they can deal with the lipids and the hypertension. So I think one of the problems with referring, right, when I first came, it got really confusing because everyone does a clinic like on their own, even the trainees was confused. There was hypertension, diabetes, lipid clinic, vascular health clinic, a metabolic clinic. Literally, there's these 5.
Yeah.
But they were just they're very separated.
Yeah.
Or coalesce, or just choosing which one they want to follow.
Mm-hmm.
Yeah, but that I can tell you, and it's only one is the lead for our outpatient.
So we need to have them all in Cerner in that vascular clinic, and then, you know, they don't need to see everybody every time. I think even once a year is adequate, right? But we need to keep them in the loop, but they come to one place and that's it. I mean, I have a 9-year-old dad, and, you know, it's frustrating taking him to all these appointments.
Yeah.
It's just crazy.
It's really
It's such a waste of time. So yeah, hopefully we can get it working. Thank you. Nice to meet you. Make sure I got everything. Okay. Thank you.
do, 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 do.